Good morning, everybody. Let me ask you to please take your seats and we'll get going on this very important topic. I want to start off by thanking Dan and Sarah, number one, for having us, all four of us here on this panel. But number two, and more importantly, for giving this topic, mental health, the airtime that I think that it deserves. We have an amazing panel. To my left in person is Dr. Sam Pullen. He's the Chief of Psychiatry with Novant Health. Also via Zoom, hopefully they'll be up here shortly, we have Sharma, who is the co-founder and CEO of WellnessCoach, and Jaki Johnson, who is the founder and CEO of WellMiss. So we are going to answer 3 questions, and we're going to answer those 3 questions based on our perspective. I'd like for you to think of mental health as a spectrum, and all of us, by virtue of being human beings, not by virtue of being flawed, but by virtue of being human beings, live in that spectrum now. So the perspective that each one of us is going to bring is going to be different, and I'd like for you to view that as a good thing. We don't have to agree because we're dealing with different parts of the spectrum that the vast majority of human beings, workers, adults, parents, children are on. The 3 questions that we are going to all answer, and I'll start each one of these questions. I'll go live to Dee first, and then to Jaki, and then we'll wrap up with you in person just to keep the flow going, Perfect. Sam. So the 3 questions that we're going to ask, and we'll follow a clinical model, if you would. The first one is, what is the current state of mental health? So just like in the clinical process, what are the symptoms? What, from our perspectives, are we seeing in the human condition? That's the first question that each one of us is going to answer. The second question that we're going to answer is, what got us here? Again, to follow the clinical process, let's do some tests. Let's find out what the root causes are. How did we get here so that we solve the right problem, so that we make the right diagnosis? And the third and last question is, what do we do? What's the solution? And you'll see different solutions based on our background. And again, I just want to underscore that that's a good thing. You'll hear different perspective, and that's a good thing. So the 3 questions. What, from our perspective, is the current state of mental health? Question number 2, how did we get here? And question number 3 is, what are we going to do about it? So I'll start, and I'll do this in rapid fire motion. It's been a long, long time since I've had notes, but because we only have 2 or 3 minutes per panelist, I'm going to go through this very quickly. So as a neuroscientist, I'm a neuroscientist. I don't have the luxury of having opinions. I deal with hard data, peer-reviewed data. So from a neuroscience perspective, this is what's going on. Number 1, the average EEG of a person alive today. So EEG is the noise in your head. It's the stimulus, the monologues, the consumption of stimuli that your brain is consuming. The average EEG of a person today is the equivalent of a schizophrenic patient from the 1940s and 50s. That means all of our brains are consuming an enormous amount of stimuli, thus the baseline level is high. On average, our mind wandering is about 65%. In the next 40 minutes, 25 of those minutes, you will not be here. And that's on average, right? The average focus time, so your ability to focus on one task before your mind wanders, is about 19 seconds. And the number 1 distraction that gets your mind to wander is not external. It's not your cell phone. It's not your text message. It's not a call. It's not someone screaming over there. The number 1 distraction in your ability to focus and your mind wandering is internal. It's your own. It's that high baseline EEG of yourself talking about something that you have to do, something that you did do, something that's going on in your life. DISC. DISC is one of the largest behavioral instruments out there, like Myers-Briggs. We have a strategic partnership with the second largest assessment company in the world. They're based out of Phoenix. They're called TTI. Every 10 seconds, somewhere in the world, someone is taking DISC, which measures your behavior. DISC. All right, some of you have taken that. In the last 2 years, we have seen the largest increase in the history of DISC. A typical increase year by year is 0.001 if it does happen. It doesn't change very much. Most of us are basically the same people throughout. In the last 2 years, we've seen a change of 2%. From a psychology perspective, that is enormous, that is off the charts. And the increases are having in the D and in the C. So in other words, as human beings, we are mutating, evolving to a more dominant and a more aggressive style of behavior without even knowing it. This has never happened in the history of that. There's still a stigma associated with mental health, with minorities, with men, culturally. In my culture, Asian culture, South Asian culture, African culture, mental health is equivalent to mental illness. It's not, but that's how it is. High ego jobs like policemen, physicians, just to talk about it is still a stigma. The P in PTSD is post-traumatic stress disorder. On the clinical side, I've been on the front lines of my patients are doctors, and I've been coaching and counseling them for 2.5 years now. And so I am seeing that most of the issues that we're going to have on the clinical side, the provider side, are yet to come. We're still in COVID. So the P in PTSD, so that is a concern. And it's even a bigger concern if you consider that in 2021, according to the NIH, 2 billion diagnoses were not made. Chronic condition as well. People didn't go to the hospital to get those done. So unlike other forms of PTSD, when you can leave the site of your trauma and go back and recover and heal, clinicians do not have that luxury. People are still going to be sick, and they will still need them to be their best versions of themselves. So this is a major issue of mental health within the clinical environment because they've gone through 2 years or 2+ years of COVID. And then lastly, and I'll pass it on to Dee, according to Lyra Health, which is one of the largest mental health companies in the world, 90% of employees say that their mental health issues come from work. So the workplace is one of the largest sources of stress and therefore mental health. From a neuroscience perspective, that's my assessment of what's going on right now. Dee, I'll throw it to you. What's your assessment of what you're seeing right now in terms of mental health?
Yeah, thanks, Izzy. First of all, all the issues you mentioned is why I suffered my own burnout, and I suffered them personally. So I think a lot of us can relate to what's happened in America and the world. 1 in 5 Americans are struggling with mental health right now. 50% don't have any treatment or any medication to support that. In the workplace, which is our focus at WellnessCoach, 80% plus are stressed or severely stressed. 50% plus are, at the verge of burnout. So it's a pretty dire situation right now, and I'm glad for this panel and I'm glad for bringing awareness to the panel.
All right, Jackie, how about you? What are you seeing?
Yes, well, first let me just say, I don't know if you ever heard the quote, the healer needs healing, correct? And so in the healthcare space right now, since COVID, there has been a surge in burnout. Prior to that, there was already a 20 to 40% surge already. COVID only amplified what our healthcare workers were going through. Specifically speaking in terms of therapists, therapists already had waiting lists. But since COVID, the American Psychological Association reported that many of its members that were surveyed were experiencing anxiety, depressive, trauma-related symptoms and disorders. But there were not enough therapists to take them on. The waiting lists were gigantic, longer than the waiting list they had in 2020. So what do you do when you have a healthcare system that already is experiencing their own burnout, their own trauma? Let's just admit it. Everyone has experienced some type of trauma. There's a collective trauma here, and we're not speaking on that. And so when you look at the therapists who also are trying to help patients, you have to look at what they've been through. The therapists too have been through trauma. So it's just looking at how do we come together to collectively support the healthcare system and what they specifically need to be great at what they do and to also be able to continue the healing. And that's looking at how do we get into even the trauma that we've all been through.
Fantastic. Jackie? Dr. Sam, what are you seeing?
So I absolutely agree with my colleagues. There's no doubt that we're living in a really challenging time when it comes to the status of mental health. I think if I were going to put a silver lining on this question, though, I think at no other time have we had more awareness, I think, of our need for mental health care, mental health services. At probably no other time, at least in our recent past, have we been more comfortable, I think, maybe at least acknowledging, if not talking about mental health and its importance and its kind of place in healthcare. We're definitely, from the healthcare system perspective, I see this on two fronts. As has already been mentioned, our workforce, our healthcare workforce, we certainly have seen the impacts of mental health when we talk about emotional burnout from our teams. And so that's certainly something that we see in terms of the status there. We also, of course, see that in our patients across the board, not just patients that may come to see me specifically for psychiatric care, but patients that are seeing providers across disciplines where mental health has an important role to play in other aspects of their health care. And so this is something that we are certainly seeing on both sides.
Fantastic. All right, let's get to the next question, which is how did we get here? We'll get to the solution as a last question, which I'm sure all of you are interested in. But it's important to understand how did we get here. And I'll start again from a neuroscience perspective. And I want to give you some color here. So 5 generations ago, right, most human beings that ever walked the face of this earth did not travel more than 50 miles from where they were born. Same stimuli, same threats, same weather, right? So imagine the cognitive consumption of those human beings, our ancestors. In addition to that, the threats that our ancestors faced were relatively the same. The average life expectancy for those people was under 40. Now, compare that to the world that we live in today, and you can begin to understand what they consumed, how long they lived, what their brain had to process, what you and I are actually doing. The change really started in the 1960s. So when it comes to mental health, you have to think of mental health as what is the brain consuming, very similar to what you eat or drink. You're putting food and water or liquid in your mouth. Cognitively, what are we feeding our brains? So it really started in the 1960s, and there's a correlation between the timeline that I'm going to share with you now and all of the other chronic illnesses and mental health. So in the 1960s, the way that we began to consume changed. We went from radio and print to now multiple radio station and TV. In the 1970s, the democracy of information and entertainment began. So now we have multiple cable channels. You can go specifically to your tribe and get exactly what you want. So now we're beginning to consume more. Now, supercharge all of that to the last 15 years with not just social media and the internet, but also the fact that there are about 14 billion devices in the world that are connected to the internet with only about 8 billion people. So there is no shortage of this overconsumption of stimuli to the human brain. What that has also done is what Jen was talking about, this secondary PTSD concept. When I was coaching doctors through the COVID, especially that first year when there was no vaccination, I found it hard to sleep after I got one of those calls. I was still processing and saying, could I have said something? Could I have done this? Could I have done that? So secondary PTSD is a very real thing. Just ask any family of a war veteran that has come back home, and suddenly their lives have changed as well. So what social media has done is that in real time, if something happens anywhere in the world, our brains are consuming it too. Our brains are also consuming a social event. Maybe you're seeing all of your friends out there having fun, and you're sitting in your dorm room doing a paper or something, or you're sitting at home. So we are sharing an awful lot of stimuli. That timeline from the 1960s to where we are now, it's not a coincidence. So let's go back to the causation versus correlation. That's the same time that we began to change in terms of clinical illness. So obesity, the obesity began to change in the 1960s and 70s. Remember, there is a concept called emotional eating or emotional addiction. Most addictions, I'm sure you can attest to this, are emotional problems or mental problems that are manifested, and it's a compensation for where essentially our brains are. Let's not forget that pre-COVID, we blame COVID a lot, but COVID was the perfect storm on top of a perfect storm. So before COVID, there was Black Lives Matter movement, there was the Me Too movement. It was a shared experience, a shared awareness, and then you throw COVID on top of all of that, and Jen is absolutely right, that is a traumatic event. Clinically, if you look at the definition of a traumatic event, it's sudden, not prepared for, impacts you, not knowing how to handle it. And we all went through it together suddenly, quickly. So we are all in some form of PTSD. The last thing I want to say in terms of how did we get here? How did we get to the point where our EEG is the equivalent of a schizophrenic patient from the 1940s and 50s? Think about everything that you've learned. We talked about tools, education, elementary school, middle school, high school, college. Raise your hand if you took a class on mental health, on your brain, on emotions. We learned all of these things. Do we use them every day like we use our brain? So we've never even been taught a language or a set of tools. It's a huge gap. Our parents and our ancestors have failed us in that regard because they haven't taught us a language, a simple language and tools to process all of these different things that are going on. So in my view, from a neuroscience perspective, the brain has been consuming. We've been trending that way since the 1960s. Our brain is not designed to consume this much stimuli, impacting sleep and all kinds of performance issues. Dee, I'll go to you. What do you see as some of the root causes? How did we get here?
Yeah, I love the way you explained this, Izzy. My favorite book is *Sapiens* with Yuval Harari. I would encourage everyone to read that book because it'll go back to like the formation of the like life, and then catches up to today, and then projects on the future with half robotic human beings and artificial intelligence and what that's going to do to our mental health. So I really think that putting that in perspective is really great. For me, it was actually having expectations of myself as a CEO, as an entrepreneur, that got me to a burnout. I think there's some basic things we deal with on an everyday basis. I was in my third startup. We were very successful. I was flying 200 days a year, and that caused it. It was pre-pandemic. What we've seen during the pandemic is there's a lot more awareness of mental health, but things are much worse. Because, how many people we know have lost their lives, how many people have lost relationships. I mean, we're coming out of it, but we're coming out of it wounded and, in a much worse mental health state than we ever were. And I think we need to still comprehend that and absorb that. So I think there's a lot more work needs to get done.
Thank you. Dee? Jaki?
Yes, just to allude to what the both of you said, I just want to mention 3 books too. There's Dr. Basil, The Body Keeps Score. There's Myth as Normal with Dr. Gabor Mate, which is a new book that just came out, and When the Body Says No by Dr. Gabor Mate. And so if we go back and we look at trauma, just to go back to what you said, Dee, in terms of the wound, trauma is that wound within. It is the impact of what you've been through, right? And so when you look at everything that's going on within the healthcare system, in addition to what's going on in just the world, patients as well, there is a level of that mind-body connection that we have to put together. The body is also manifesting all that's going on. So to get to the root cause, truly, we have to also look at what the person has been through, in addition to looking at the symptoms as well. So when you look at workload, you look at emotional distress, you look at all these different issues that's happening. If we're going to look at the root, let's look at the whole person. Let's look at the whole story. Let's see what it's telling. And so once we do that, that's when we can then really start to heal, is we have to look at everything and not just the mind, but the mind-body connection, because it's all interconnected.
Fantastic. Thank you. Sam, how do we get here?
Wow. Well, it's a complex question. I love that my colleagues have referenced some really great books. I think that attempt to speak to that, and I think it speaks to the complexity of trying to answer a question like this. And I would just echo and recommend the books book titles that have been shared. The author that I like, he's a little bit more technical, but Vikram Patel. He's a psychiatrist who's written a lot about global mental health, and so has looked at mental health across cultures, across countries, and so forth. And so that would be another author that I would recommend if we're trying to get our arms around a question as complex as this. I think, as has been said earlier, there's an important distinction when we're talking about patients that we care for that may suffer from serious and persistent mental illness, like schizophrenia or like bipolar disorder. And when we're talking about kind of the state of mental health right, which has impacted, I would say, nearly everyone in the room, certainly in these past several years. And I think important to underscore and understand the intersection between mental health and our physical health as we think about individually, but really the impact of mental health on society and all of the interplay between a whole host of different factors. I would underscore a couple of important factors that predate COVID, but I think have been exacerbated by the pandemic. One is just looking at, right before the pandemic, the CDC had released 15 years worth of data where it had been tracking suicide rates by state over the past 15 years. And in nearly every single state, I may be wrong on this, I think it might have been Nevada, but there was only, I think, one state where the rates of suicide were not increasing. In nearly every single state, the rates of suicide were increasing, and in some states, dramatically so. Suicide itself is a very complex topic. There are lots of factors that people that study suicide and try how to prevent suicide, there are a whole host of factors that have contributed to those rising rates that we just don't have time to talk about in the panel discussion today, but would be happy to answer questions about that. And then I think the opioid epidemic would be another important, really kind of important topic to talk about. And it's no, I think, coincidence that suicide, the opioid epidemic, that have really kind of, there's this intersection between those components, the rise of things like social media, and not saying that social media is a causative agent of those things, but it certainly speaks, I think, to and has perhaps contributed to things like our disconnectedness as a society, as people. Our brains have not been able to keep up with some of our technological advances, right? We're still hardwired to have meaningful in-person conversation and social connectivity with one another. And so that's been something that has been altered by the technology and some of the things that we've looked at. And so the pandemic, of course, has been an accelerant. It's exacerbated, I think, a lot of these issues and challenges, and have created new challenges by some of the things that we've tried to do to help curtail the pandemic, but that's had its own set of consequences.
Thank you. Thank you, Dr. Sam. All right, let's get to the solutions. So what are we suggesting based on our different perspective as the solutions? So I'm going to come at it from a neuroscience perspective, not a clinical perspective. And as you just said, I completely agree with Dr. Sam that we have to think of mental health as a spectrum. And in the middle would be mental health or mental wellness. There is a lot of noise in our head. We do have anxiety because we're human beings. We have kids that have issues, or parents, or jobs, or traffic during a normal day. Just dealing with normal stressors, that's where I'm going to focus on. On the left side of it is what Dr. Sam was talking about, where it's really mental illness, or more on the clinical side, like clinical depression and anxiety and those kinds of things. And then on the far right, I really do want to challenge you to think of mental health as also a performance issue. So if you think about yourself, why are you hired? Why do you hire somebody? And you'll say, oh, because of their skills and their abilities and their past experiences. Well, I will ask you, where is that? Is it in their liver, in their kidney, in their legs, in their car, on a laptop? No, it's in their brain. So really, when you yourself hire people, you are hiring a brain, because that's where everything is stored in the human being. Muscles have no memory. There's no other organ in the human body that stores memory. So if you are a manager, if you're a leader, if you are a parent, if you are a human being, you cannot ignore the role of your brain and the illiteracy that you have had through no fault of sort of anyone around that. I'm going to propose two solutions, both of which have been done, and there's a little fire on the chairs for you. So one is, I'm going to ask you a silly question. You will laugh at this question. Why do you need a vacation? Why do you need a weekend? Have you asked yourself that question? Maybe not. But you'll probably say, well, I need a break. What part of you needs a break? And from what? Well, you need a break because you've worked 5 days or you've worked 6 months and now you want to go on a vacation with your family. I will tell you that the weekend model and the vacation model was predicated on a working model and a mental stimuli consumption pre-1960. When your brain was consuming this much stimuli, taking 2 days out of 7 to go do other stuff was a good thing. Going on 2 or 3 vacations was good. The mental stimuli and mental consumption is so high right now that there is no way that those 2 days and vacation is enough. Now, we can't go about giving everybody 6 months of vacation and giving 4 days of work week. It's not practical. So the way that we think about it has to change. We have to insert the concept of a weekend and vacation into the workday itself. For those of us that are adults that work somewhere, what stresses us out more than anything is when we underperform at the task. I work with a lot of athletes. When they lose, you can lose twice. You can lose because you got beat, or you can lose because you underperformed. These are not the same thing. When you lose because you underperform, you didn't remember something to say or do, that's when you beat yourself up, and that's when stresses happen. So from our perspective, from a neuroscience perspective, we think that the answer is everyone needs a language and a set of tools that they can integrate into their workday. Therapy and counseling, I'm a huge fan of that. My father was a psychiatrist. I'm a huge fan of the work that Dee and Jaki and Sam do. But there's 8 billion people in this world, and we're all on that spectrum. It is really difficult to get an appointment with a therapist or a counselor. So I want to save that for the people that are on the further left side of it. We need to trust each other that if we learned about our brain, learned a simple, non-judgmental language about our brain, the language that you've been using is a prehistoric language: mad, glad, happy, sad, annoyed. These are labels our Bronze Age ancestors came up with to describe our mental state, who didn't even know where the sun went at night. They're not accurate. It doesn't reflect the condition of your brain and the EEG. It's too tall a task, in our view, to say, okay, go do yoga, go on a 3-week retreat somewhere, go do cleanse yourself. For most people, it's not practical. So we have to get into the idea of inserting into the workday itself, into the normal life. As our brain is consuming all of the stimuli, we must proactively put deposits, cognitive deposits, healthy experiences into our cognitive sphere so that at the end of the day, the cognitive bank account is more balanced, which is completely unlike where most of us are, which is why we're not sleeping very well, which is our brain is recording, storing, and retrieving and replaying the negative experiences of where we are. So Neuro 580 is a program that's developed that language based on neuroscience. It's developed very simple neurohacks that you can do in seconds that can have the equivalent impact of a 20-minute walk or 30-minute yoga cognitively as measured by the EEG. So that's our view on what you can do or what you should be thinking about is at the end of the day, think of yourself, the people that you work with, the people that you work for, your family members as a human brain whose EEG is high. So what can you do? What can you insert through the course of your day to bring that down, to reduce the stress so that it doesn't accumulate day after day, week after week? Dee, I'll pass it on to you. I know you're doing some amazing work with WellnessCoach. I'm sure they're very excited to hear about all the good work that you're doing.
Yeah, this is a very long potential answer, but I'm going to keep it short. I'm not a physician like most of you are. I'm a nerd engineer, serial entrepreneur. So for me, I've been very curious on how do you find a solution and how do you measure it. And today we have hundreds of global companies that provide WellnessCoach to their employees. And we saw that the number one thing is having leadership talk about their own mental health issues. So when it comes from top down, when it comes from the culture within, it is very impactful because like you said, Izzy, earlier, there is a stigma and there's still a stigma with men. And despite the pandemic, it's just hard to say, I want to get a therapist. I have a therapist personally, but there's still a barrier. So we call everybody coaches. It makes it a lot easier to book your first appointment rather than calling you the therapist. But then secondly, we work with several hospital systems, like for example, with Yuma Regional Hospital System. If they do coaching sessions, they actually can get CME credits. And that's a reward system. So can you create a reward system to take care of your mental health? And if you can get leadership and a reward system, now you've got a framework where at least there's engagement with the coaches and the therapists, right? First is engagement. Then the second piece is measurement. And I'll leave that to the next time I'm at this conference, because we're partnered with the largest insurance company and we're doing amazing work there that I just cannot share right now. So I'm going to hold that and I'll show up again and I'll tell you all about it next time I'm here.
All right, wonderful. Jen, I got to find out more about your work and your background, and I'm really excited for them to hear what you're doing with WellMiss.
Yes, at WellMiss, we are the first trauma-informed, holistic, and integrative care platform for women on their trauma healing and well-being journey. We know that 1 in 2 women will experience at least one traumatic event or multiple events in their lifetime. And so we're here to help on that journey. We know that data shows that not only is the mind affected, but also the body. And so that's when we bring that whole person care to the table. But to answer this question, just in terms of solutions, I have 4 suggestions. And the very first one is to create a trauma-informed healthcare system. We really do need that, because even in the midst of what we've been through and where we're at now, we're all still healing. And so to have trauma-informed care, just to know how to do that, how to deliver that, is very important. That will help everybody, including the healers who need the healing, right? Second, just collective support, having care teams that are in place who are gathering as much information as possible, so that by the time you get to a therapist or a doctor or a practitioner, a lot of the information has already been curated, put together in the patient profile. And the doctor, the therapist, the practitioner can have more time with the patient. That's a big thing, that collective support, helping to give back time. The third thing would be work environment, making sure the work environment, just alluding to what you said, Dee, in terms of leadership, make sure that leadership is showing, being authentic, showing what they're going through as well, creating a mental health and well-being atmosphere that really supports what our practitioners are going through. And then lastly, financially, a lot of therapists, one of the things they say to us is, we don't get paid enough. We don't get paid enough. We stopped taking insurance. A lot of therapists are going independent and not taking insurance because they're not getting paid. So if you're already dealing with trauma and what you've been through and what you're watching and how you're helping other patients, and now you're going through your own trauma because of the aftermath of COVID, and we're still in it, but yet you're also not getting financially paid the way you would like to. So just think about that added layer of worry that comes when you're not even getting financially compensated, which you should. So just thinking about the equitability across all, it's going to take insurance, it's going to take the health system, it's going to take everyone to play an equitable role to really help with the financial aspect, the work environment, the collective support, and to create a trauma-informed healthcare system.
Fantastic. Sam?
All right. Well, I like to think about this question not so much in terms of what are the specific solutions. There's a number of solutions that we could talk about, that we could think about, and I'll give an example of one solution that we are working on at Novant. But I think of it more in terms of, what are our solutions trying to solve? What are the problems that we're trying to solve for? And if we kind of think about it in those terms, then I think that gives us room to be creative, to be innovative, and to really kind of think about how we're approaching this particular problem and challenge. I love Jackie's response around trauma-informed care. I think of the analogy of being on the airplane, right? Health systems, providers, anyone who's in the healthcare industry, we need to put our own oxygen masks on first, right, before we can be the helpers that our professions have called us to be, before we can put the oxygen mask on our patients. So I think that's a critical element. So I'll let what Jackie said stand for itself there. I think in the space of patient care, when it comes to mental health, I think we really are needing to pursue a strategy of going where our patients are. So in traditional healthcare, we waited for patients with mental health or mental illness to come to us, to come to the clinics, or come to the inpatient psychiatric units, or to come to those places to get care. And they come to those places from all different sources. But the vast majority of mental health care is delivered in places like primary care, It's delivered in the emergency department, and it's delivered up on our medical hospital floors. And so I think one of the big problems that we need to solve for is how do we take mental health care to where our patients are going. And so one of the strategies it's kind of old hat, it's old news by now, is, we've talked a lot about integrated care. A lot of health systems are pursuing various strategies around trying to integrate mental health care into these kinds of settings. But I think there are still a number of challenges to be able to take that to scale, to make that a sustainable and viable model. And so I think that's where we start to think about what are some of the different components that could be helpful. So thinking about how we might use things like technology, how we might use different methodologies to educate our teams, our providers. How do we work with them to kind of think about mental health as part of healthcare in a holistic fashion? So I think those are some of the solutions that are out there that I think we still have a lot of opportunity around to pursue.
Fantastic. We have about 6 minutes left. I think we have time for maybe 1 or 2 questions, and then I would like to wrap up with a challenge for all of you. Yes, ma'am. The mic's right behind you. Thank you.
Hope that was loud enough.
Yeah.
What do you believe is the optimal model for mental health support or services in schools?
Right, that's so great question. Well, one, as a child and adolescent psychiatrist, that question is near and dear to my heart. I think it's probably it's a combination of different ways that you could approach that. One, I think, is thinking about how do we partner or collaborate with schools. So schools may vary in terms of what are some of the challenges they're facing in terms as it pertains to mental health care, not only for the students but also for their staff and team members there. So I think the first approach is coming alongside and partnering with them. I think that's part of the role that we have in really engaging in that question. I think there's often opportunities to educate school staff. So especially if we're in a space or environment where we have limited, finite resources, including human resources, a lot of it might be teaching team members at schools how to better identify students that may have mental health concerns. What is their role in engaging and helping those students to get appropriate help and services? And then I think there's also opportunity for schools that are really interested or asking for services, opportunities to help to really, again, integrate mental health services. And so Novant, I know, is along with other health systems in North Carolina have started looking at how may we integrate mental health care into school settings. There's different challenges and things considerations that you have to take into account for, but those I think are some of the ways that we could help schools.
As a parent of 2 children, I have a complementary answer. I agree with everything that Sam said, and what I'm suggesting is, in addition to what he said, because I agree with it, not in lieu of. To me, we have to fill the void that was created by generations past. I have 2 children. They understand emotions very well. A 2-year-old knows when something sad is going on. Their EQ is off the charts. They have very powerful emotional instincts. So the time has come to teach, to make it part of the curriculum. It's not scalable to have outside therapists and outside people. We have to teach children from the very beginning and repeatedly. It's got to become part of the curriculum. So my solution is, if there's an accurate neuroscience, clinically based language and a set of tools that they can use, like children can use it. Children can be taught how to breathe. Children can be taught how to use their senses. Children can taught how to be present. Children can taught how to do yoga. All these kinds of things need to be a part of the curriculum. They should be just as important as civics and geography and algebra. because these kinds of things that we're talking about is something, these are skills for a lifetime. We use our brains and emotions in every experience. All right, we have time for one more question.
I'll maybe add a
Dee,
quick
go ahead.
thing to that.
Go ahead,
Yeah,
Dee.
because we power one of the top 10 school systems here in America, and I think what we are powering educators, not students, but I think what we forget is what the educators went through during the pandemic. Are the schools open, not open, not open, mask, no mask, parents are getting mad. I mean, it's been really, really bad for educators. It's the same way it's been for the physicians. What we found is access to good care is the problem. Even though health systems say they have it, finding it and finding availability has been really, really challenging.
Matt?
And I'll just say one thing too. I'll just go back to what I said earlier. The same thing with trauma-informed healthcare, definitely include having a trauma-informed model, even for teachers as well, because a lot of what children are going through can also stem from trauma, from what they've been through. And so just being informed and knowing that we can make another change. We can help them even more. So check out this documentary called The Wisdom of Trauma, where they really get into trauma in the school system and how if we start to look at that, we can help a lot of students along the way.
I have a quick question, and I'm coming from a place of being a combat veteran who's seen a lot of trauma, see a lot of colleagues go through difficult times. And one thing the military and the Veterans Affairs Department does well is teaches post-traumatic growth and before going on in combat resiliency training. So wondering if we can do more preventative work, or if any of you can talk about more preventative work. And then second, at Novant, we're looking at innovative approaches like ketamine and psychedelics and virtual reality and other mind-body connections. So if anyone could talk a little bit more about cutting edge things you might be looking at, or if you see any efficacy there. Thank you.
You want to take that? Why?
Yeah.
Sure. So absolutely. We've been working with DARPA, who is the part of the research facility of the DoD for 15, 16 years. And that is a very good case study. If you look at all of the PTSD interventions that are out there, the efficacy, the best efficacy model, including EMDR and all those kinds of things, psychotherapy, is roughly about 20%. The message there is that what works for one person or one culture or one group of people does not work for everybody else. So the more tools that we have, the better. So it's not one thing or two things. The other thing, I think the reason for that very limited 20% maximum efficacy of any PTSD tool is because every single person's EEG, which is based on their life experiences, the trauma that they experiences, their role in their trauma, all those kinds of things. Were you the victim? Were you the perpetrator? Those kinds of things plays a large part in where your own EEG is. So there are more and more tools that are coming out there. I will go back and please forgive me for repeating this. As a human race, we do not have a language to talk about this. If you say you're mad and she says she's angry, what's the difference? You could say the same answer or you could say the different answer. There are 88 emotional labels out there. None of them reflect a cognitive state. They mostly behave a behavioral state. So we have got to give ourselves, we have got to accept that if we had a language to process what's going on in our own head, we are resilient creatures. We're no different than any other living creature. We are survivalists. We can do anything that we want to. But if we don't understand, we're solving the wrong problem oftentimes. So the language, in my view, is a key part of the solution. Just another minute. So Dee and Jen, do you have any addition to that? I know, Jen, you've done a good work with PTSD.
Yes. I mean, just post-traumatic growth. I mean, that's what we're looking at too, is really how to go from what we've been through to growing in that resiliency. We are aware, though, that in this healing journey, as you heal with trauma, there might be some spirals. There might be a living duality where you live between the growth and you still live between potential triggers and things that kind of bring you back to what happened. So we're also doing work around how do you really support that healing journey as it regresses sometimes. How do you help move forward and propel with the post-traumatic growth? And so, yeah, even like what you said, ketamine, psychedelics, we're looking at all those things as well. And at what point does it play a role in her healing journey and what is she ready for? We've noticed some WellMiss are ready to talk about what they've been through. Some WellMiss are not. So we've had to really look at how do we position even the word trauma, because for a lot, the word trauma is uncomfortable. So even just beginning to have a conversation and making it okay to talk about trauma, just opening that up, I think that's a big start. It's just having the conversation around trauma so we can eventually get to that point where we're having post-traumatic growth.
All right, thank you. Dee, I want to thank you. Jaki, thank you very much. Jaki-san, thank you very much. And I'm around. I know we are both around if you want to ask a few more questions of us. But thank you so much for allowing us to share this topic with you all.
Thank you.
Thank you, everyone.
Thank you.
Sorry, guys. I feel like I get to be bad cop today while everyone gets to ask really good questions. I step in and say no more. Sorry, conversation over.